Welcome to this video entitled Acute Primary Stroke Module. As a way of introduction, the Aga Khan University Hospital was certified as a center of excellence for the treatment of patients with acute primary stroke in the year 2021. This is known as Clinical Care Program Certification, abbreviated as CCPC, for acute primary stroke. In clinical practice, it has been proven that early treatment of stroke saves brain and prevents long-term disability, hence the phrase, "time is brain," amongst neurologists and neurosurgeons. The Aga Khan University Hospital is committed to save brain by providing a system that facilitates early diagnosis and treatment of stroke patients admitted at the institution for care. We will now briefly discuss the Acute Primary Stroke CCPC program. The CCPC program gives utmost priority to patients presenting with features of acute primary stroke. As such, outpatients with signs of acute stroke should be directed to the accident and emergency, abbreviated as A&E, while management of inpatients should be commenced in the ward therein when stroke develops. These patients suspected of having acute primary stroke should be triaged and reviewed within 10 minutes of arrival to the accident and emergency or onset of symptoms in the ward for inpatients. Patients with acute primary stroke should have a head CT scan done and be managed according to the stroke care pathway. We will now address the query, what is acute primary stroke? Acute primary stroke is defined as a sudden reduction of blood supply to a part of the brain due to the presence of a clot or rupture of a blood vessel in the brain, resulting in brain damage, long-term disability, or even death if not well managed. Acute primary stroke is stroke occurring within the last 7 days and not associated with secondary causes, for example trauma, tumor, among others. The types of acute primary strokes include those listed below. 1. Transient ischemic stroke. 2. Ischemic stroke, which can be thrombotic or embolic in nature. And 3. Hemorrhagic stroke. Let's now pause the video and carefully scrutinize the illustration of thrombotic and embolic strokes, which are both types of ischemic stroke, before advancing to the next slide. I would now like you to pause the video and carefully scrutinize the illustration of hemorrhagic stroke before advancing to the next slide. We will now shift gears to the acute primary stroke care pathway. The acute primary stroke care pathway should be initiated by any clinician, that is either nurse or doctor, upon suspicion stroke. When a patient presents to outpatient areas with suspected stroke, they should be sent to the accident and emergency department where the acute primary stroke care pathway is initiated. The pathway can also be initiated in the ward on suspicion of stroke for an inpatient. All patients with acute primary stroke should be commenced on and managed in accordance with the acute primary stroke pathway. We will now focus on the diagnosis of stroke and time of onset of its signs or symptoms. The cardinal signs for acute primary stroke are facial droop, arm drift, and abnormal speech. The stroke may have a known time of onset whereby a patient is able to tell the last time they were normal. Stroke of unknown time of onset occurs when a patient wakes up with a stroke or when a patient can't recall when last was normal. We will now progress to the inclusion and exclusion criteria for the program. The inclusion criteria for acute primary stroke pathway are: 1. The stroke should have occurred within the last 24 hours. And 2. The patient should be above 18 years of age. The exclusion criteria for acute primary stroke pathway include: 1. Stroke symptoms present for a duration longer than 24 hours. 2. Patients below the age of 18 years. And 3. The presence of subarachnoid hemorrhage. And now we will address the query: what should we do for acute primary stroke patients? Patients presenting with acute primary stroke should be seen and reviewed within 10 minutes of first medical contact. A head CT scan should be done and reviewed or interpreted by a neurologist within 45 minutes. Intravenous thrombolysis, abbreviated as IVT, intervention is offered to patients who have less than 4.5 hours from onset of stroke symptoms. Intravenous thrombolysis should be done within 60 minutes from first medical contact, abbreviated as FMC. Endovascular thrombectomy, abbreviated as EVT, should be done within first 75 minutes from first medical contact and is offered to patients whose symptom duration is 4.5 to 24 hours. And now we will address the question: what should we do for acute primary stroke patients? The National Institute of Health Stroke Scale score, abbreviated as NIHSS score, should be done at first contact, that is at baseline, during initial patient assessment and diagnosis, and at 1 hour and 24 hours post-intravenous thrombolysis, abbreviated as IVT, and post-endovascular thrombectomy, abbreviated as EVT. Patients with stroke should be admitted to the critical care units. For the Aga Khan University Hospital, the primary critical care unit for stroke admission is the high dependency unit. Patients with subarachnoid hemorrhagic stroke upon diagnosis should exit the pathway, and a neurosurgeon should be informed about their case or cases. We will now take a closer look at the interventions for acute primary stroke. Intravenous thrombolysis, abbreviated as IVT, involves the use of alteplase or tenecteplase to dissolve a clot after meeting eligibility criteria. At the Aga Khan University Hospital, there is a thrombolysis kit available. The total duration from onset of symptoms to thrombolysis should be 4.5 hours. Thrombolysis can be performed by the physician or nurse once the decision to thrombolize is made. The thrombolysis eligibility criteria must be met before a thrombolytic agent is administered. Informed consent must be obtained by the physician from the patient or next of kin before the thrombolytic agent is administered. The duration from first medical contact to thrombolysis should be 60 minutes. After thrombolysis, the patient is observed in the high dependency unit under continuous monitoring. An NIHSS score is performed at 1 hour and at 24 hours post-thrombolysis. We will now shift our focus to endovascular thrombectomy, abbreviated as EVT. The procedure involves using a specially designed clot removal device inserted in through a catheter to pull or suck out the clot to restore blood flow in the brain. The decision to perform thrombectomy is made by a neurosurgeon based on a defined eligibility criteria. Patient will qualify for thrombectomy if duration of symptoms does not exceed 24 hours. The duration from first medical contact to thrombectomy should be 75 minutes. The procedure is done in the catheterization laboratory. Informed consent should be obtained before the procedure. Let's now consider other care for acute primary stroke. Swallowing or dysphagia screening should be done before the patient begins eating, drinking or receiving oral medications for patients at risk for aspiration. A speech or language therapist works together with the nurses to help patient relearn language and speaking to include swallowing if affected. The physiotherapist should be able to commence passive exercises 24 hours following admission of the patient and intervention for a stroke. Counseling is done to help patient and family cope with emotional aspects of stroke, as stroke patients often suffer from depression, anxiety, frustration and anger, We will now briefly look at occupational therapy. These therapists help patient relearn hand and arm use for daily skills such as bathing, dressing, and using the toilet, among others. And now we will take a brief look at stroke patient discharge. The discharge medications for the stroke patient are counter-checked by the pharmacy team. This ensures all indicated medications are delivered at the right doses. Such medications include high-dose statins, antihypertensives and antiplatelets or anticoagulants as appropriate. The pharmacist assesses for all possible side effects, drug interactions, and intolerances, and appropriately educates patients or family members. Once patients are discharged, the CCPC team follows them to ensure they are reviewed at the neurology or neurosurgery clinics and are taking medication as prescribed. Any side effects are assessed by the physician and medication doses adjusted if need arises. We will now briefly discuss patient or family education. Patients with stroke require education on the following key areas. 1. Stroke recognition, paying attention to facial droop, arm drift and abnormal speech. 2. Stroke care, bearing in mind that time is brain. Ensure patient is taken to a hospital immediately. 3. With regards to follow-up, ensure you follow the doctor's instructions carefully. 4. If patient has hypertension or diabetes mellitus or high cholesterol or heart disease, make sure these conditions are well controlled. 5. If patient is a smoker, smoking cessation education is vital. And 6. Medications are taken regularly as instructed by the doctor. Finally, we will discuss the disability assessment using the Modified Ranking Scale assessment. Regarding the Modified Ranking Scale score, abbreviated as MRS score, this is done at 3 months after stroke. The score is from number 1 to number 7 as summarized below. A score of 1 denotes no symptoms at all. A score of 2 denotes no significant disability despite symptoms. A score of 3 denotes slight disability. The patient is unable to carry all previous activities. A score of 4 denotes moderate disability, e.g. a patient requiring some help. A score of 5 denotes moderate severe disability, e.g. a patient unable to walk. A score of 6 denotes severe disability, e.g. the patient is bedridden. And a score of 7 corresponds to a dead patient. Thank you.